Thanks so much, Jason. Hey, everyone. It's great to see everyone here tonight at our Action Potential series on the role of physical therapists in the emergency department. So first, I'm going to introduce Dr. Rebekah Griffith. Rebekah graduated from the University of Colorado with her Bachelor of Arts degree in kinesiology and applied physiology, followed by a doctorate in physical therapy. She has since become a board-certified neurologic clinical specialist, and she is a fellow in training at Regis University. Rebekah currently works part-time as a PT specializing in emergency and intensive care at University of Colorado Hospital and as an appointed clinical instructor within the University of Colorado School of Medicine. Rebekah serves as Colorado Chief Delegate for the APTA and serves her community as a clinical preceptor at the Dawn Clinic for the Uninsured in Aurora. A devoted mother of 3 amazing children, Rebekah has served as a classroom parent for years and can routinely be found volunteering in many roles throughout Skyview Academy. In her spare time, you'll find Rebekah at the movies, enjoying the beautiful Colorado outdoors with her husband, following the Colorado Rockies, and chasing her children. And so next up, we have Dr. Kyle Knauff. Kyle is a 2006 DPT graduate from Marquette University. He worked in outpatient physical therapy and sports medicine in Chicago and Madison, Wisconsin for 10 years, and he became an orthopedic certified specialist in 2012. He made the transition to inpatient PT and started Unity Point Health Meritor's Emergency Department Physical Therapy Program in September of 2017. He has since presented at state and international conferences on PT in the emergency department. In his free time, Kyle likes to spend time with his family and watch Marquette basketball and Arsenal Football Club. So before we get started, go ahead and introduce yourself in the chat. Tell us where you're from, where you are in your education if you're a student, where you're currently practicing if you're a clinician, and the populations you primarily treat. If you'd like to continue the conversation, like Jason said, tag us on Twitter or Facebook at PT Journal. We also encourage you to turn your cameras on for this event. And now I'm going to hand it off to our guest speakers.
Hi, everybody. I'm Rebekah Griffith. I am a physical therapist at University of Colorado Hospital. I have been there for 11 years, which makes me feel a little bit on the older side, but I leveled up to 40 this year, so I guess that means I've earned it. And we started our ED-PT program in 2016 as a month-long pilot, and we have not left the department since then and are looking at a new pilot program starting in January with some other facets of emergency practice, which we can talk about a little bit later. I'm so glad you're here. This is absolutely one of my favorite things to talk about. I love hearing people's perspectives. I love lots of questions about this. I like talking about case studies. So let's be as interactive as possible. If you can have your cameras on, that is so much better so we can see your faces, but if not, that's totally fine. I have a lot of embarrassing laundry piles in my room. I don't know what you've got happening in yours, but I get it, whatever it is. So don't be afraid to turn your camera on and jump in.
I'll introduce myself as well. My name is Kyle Knauff, physical therapist in Madison, Wisconsin. Like I said in the bio, I started our program with a couple other people in September of 2017. In the same way, we started and saw, I think, like 4 referrals the first month, and have grown since then to what we are now. And like Rebekah said, they can't get rid of us now. I mean, we're pretty integral in everything that they do down there. So yeah, I echo the same things. I'm excited that everybody's here. I have a lot of takes on emergency department PT, how important we are and things like that. We're new grads, their role kind of fits in, I feel like. So yeah, feel free to ask any questions that you guys might have.
So Devon, how do you want us to start? What's a question that you have, Devon, just to kick us off?
How did y'all discover emergency PT, and how did you get started, and how can we get started as students? and what's some education that might be missing from the current curriculum, and how can we kind of get that on our own?
That's a lot to unpack. So I'm going to start at the beginning. So for me, my exposure to emergency department physical therapy was, we had at the time a fairly small emergency department with about 37 to 40 beds. When it was bad, like folks were in the hallway. And I would be managing a caseload in our acute care hospital, but then I would carry a pager. And if they needed me to come down there to see somebody because they couldn't discharge them for whatever reason, then they would page us. And so every once in a while, maybe you'd see one patient, maybe you'd see two, then you wouldn't see any for 3 weeks. And it turned into this like bigger and bigger issue where, which caseload were you supposed to be managing? Were you supposed to be managing the patients in the emergency department or all of your patients in the trauma ICU? And so it got to the point where the demands on our time became so inconsistent, it was really difficult to staff for that. And I had also attended CSM several times and heard like the OGs of emergency department physical therapy presenting. This has been around for 15, 20 years. And other countries obviously are way further ahead of us, both in Canada, the UK, Australia, New Zealand, as far as I know, light years ahead of us in this practice. So I was exposed to it in those areas. Also, the APTA had an emergency department toolkit, like how to start a program in your hospital. And so after attending a CSM as a student, where I heard a little bit about emergency department PT and then going on to be responsible for some of these patients, I thought, well, it's time to see what we can do. And so in one of my job roles, I'm a physical therapist specialist, which is just a role on our clinical ladder. One of my job responsibilities was to create something, a quality improvement initiative, better patient care, in any way that I could do that. And so I turned my eyes towards emergency department physical therapy. And by using the ED toolkit that the APTA had generated, it was really very easy. We met with the stakeholders in the emergency department, and we basically presented the presentation that the APTA and those who had gone before us had created, those who had done the research, done the practice, put in the time to create this as a practice area in physical therapy. And the director of the emergency department just kind of kicked his feet up on the table and was like, come on down, we'll just see how it goes. And I was not expecting that. Now that I've worked in the emergency department for a while, I know that like devil may care attitude is pretty common. So I'm not surprised now looking back that they were so just like, hey, yeah, the more the merrier, come on down. And so we started with a 1-month pilot program. And our threshold for success at that time was, are you meeting your productivity? Because of course, right, we're physical therapists. Are you meeting your productivity? Are the providers in the emergency department satisfied with your care that you're providing? And are the physical therapists feeling good about working in this environment? And so we found that it was remarkably easy to meet our productivity. Unlike Kyle, our first week, we were slammed. They were just so curious about what we could do that we didn't eat lunch. There were just patient after patient after patient. I think it was I don't know if it was hazing or if it was just this is new, let's give it a shot. And we saw so many patients, and so our productivity was a non-issue. We were by far and away exceeding our productivity requirements and expectations. And then we gave a survey to the providers at the end. We surveyed attending physicians, resident physicians, advanced practice providers, and our case management staff to see, and I think we asked maybe 3 questions. And one was, do you regularly consult PT in the emergency department? And the answers were yes, almost everyone consulted PT. And then the second question was, physical therapists in the emergency department allow me to provide better care to my patients. And the response was 92% strongly agree and 8% agree. I've never seen a survey where there was nobody neutral, nobody disagree, and nobody strongly disagree. So for us, that was it. And all the open-ended comments we got were, you guys are worth your weight in gold. Your bedside examination skills are outstanding. I had no idea your scope of practice and the training that you go through. Can we make this permanent? And there's no way we can go back to the way we began. So that's how we started. I'll let Kyle share how his program launch went.
Yeah, we just kind of hung out down there. And eventually we were able to look at the board and we would talk to the physicians and say, I think this patient would be appropriate. This for PT, what do you think? Kind of discuss it with them, and then they would say yes, or they would say, no, I don't really think that they would benefit that much. Kind of get slapped down and then move on to the next patient. And eventually over months, basically, it kind of grew to where we are at right now. While she was talking, I was kind of thinking about the fact I think we struggle with nationally as leaders in this program is like no one good one size fits all for every emergency department in every hospital. I can't take what we do here and go to the hospital, other hospital in town, or go out to Colorado where Rebekah is and implement a hospital there. A lot of it matters on who your physicians are. Are they going to have a big buy-in there? How much is your administration going to help you out? Are they going to be willing to have you sit in the emergency department and possibly not see anybody for a long time while there are patients maybe up on the floor in the hospital that need to be seen? And do you have therapists that are willing to be flexible, like Rebekah said, seeing patients over lunch? Rebekah and I always laugh on Twitter about staying late, which happens practically every day when you're working in the emergency department. Last night I was supposed to leave and I had 3 patients within the last hour, which means I left like an hour and 15 minutes after I was supposed to. And that sometimes happens.
I call that 4 o'clock special. Exactly.
So you have to have buy-in at all these levels in order to have a successful program. And I think that's difficult to implement from hospital to hospital. I know somebody asked in the chat too, like what's a typical day is you come in and there's already an order consult on the front desk and it's been there for an hour and nobody's picked it up for us. So I would go down there and see it right away. And I may not have anybody for a couple more hours, or I might have 2 or 3 more in that morning right after that. Or I might see a couple in the morning and then there's nobody in the ED for me to see the rest of the day. Like you talk about 4 or 5 o'clock, there's 3 or 4 more, and then you're staying late. So typical day varies, and you have to have somebody that's very, very flexible in order to work in this environment to kind of go with the flow, basically. Some days are great, busy, other days are going to be a little bit slower. So, yeah.
So if you're not able to go to just like, a different hospital, like say in a different state, what gaps do you each uniquely fill in the emergency department? Like what's like specific kind of roles in like the multiple, or not roles, but what gaps? In the gaps.
So I think Kyle and I can compare and contrast our 2 hospitals. I said when I started that we had about 37 beds in our emergency department. It is well over 100 now. So our emergency department is more than tripled in size. So we can easily sustain a physical therapist 7 days a week. We are looking to add a second physical therapist for just one portion of our emergency department in January for a pilot program, where we'll take direct triage of all of the musculoskeletal pain patients and vertigo patients that come in that are deemed not to be a life-threatening emergency. So those folks will come into our super track area, which I like to call who should have gone to urgent care. And those patients, instead of seeing a nurse practitioner or a physician assistant, will actually see a physical therapist directly, and we'll manage their care while they're in the emergency department. The other physical therapist will still be responsible for everything else in the emergency department. But because of the demands we have based on the number of beds that we have, we actually really probably need to have 2 full-time physical therapists. Also, our emergency department is a large academic medical center in an urban environment. So many of our patients are underserved. They are underinsured or uninsured. They are lacking in secure housing. They are sometimes lacking in the ability to speak English as a first language. So we see a huge diversity of patients. And I would say the hospital that's 5 minutes from my house, it's not like that. They see primarily private pay insurance, Medicare insurance, patients who have relatively high health literacy. I don't know that we would have such a demand at that hospital as we do at our hospital, because our patients are so underserved and may not know where to go or what to do or what they need. And so I think that's part of why we can sustain a physical therapist, but I can't take what I've done and drop it in this community hospital down the road that has maybe 100 beds, whereas my hospital has 800 beds overall. So I think some of it is size, some of it is patient mix, some of it's payer mix, some of it's your providers and what kind of treatment options and care they want to provide to their patients. Our hospital is very much dedicated to helping curb the opioid epidemic. And so by offering physical therapist services, that's another thing. our hospital believes in and can offer to help our patients with pain control. So I think it just depends on so many different factors, and that's where I see some of the gaps.
Now, can I ask one follow-on question to that? I think about, I've worked in the Dawn clinic where you also work and got referrals from that emergency department before. So I think about like the unique vision of a physical therapist in the ED to recognize a need for follow-up care and have the time to coordinate it. Do you think there's certain patient populations who are better served seeing a PT than another provider in the emergency department? And like, what do we do better than other providers, or maybe just have more focus on that is really benefiting certain populations?
Well, I think just from your connection about the Dawn clinic. So for me, so many patients have never heard of a physical therapist. And for so many patients, physical therapy is a luxury. It's like going to a restaurant with cloth napkins. It's like something that they cannot do based on their life circumstances. So for me, I don't go to a restaurant with cloth napkins because I have 3 children. But my point is, like, accessing physical therapist services is completely out of reach for so many people. But in the emergency department, I can give them that. And for me, that's the biggest gift, is when I can give physical therapist services to people who might never in any other circumstances be able to access it. And having resources like the Dawn Clinic to be able to refer patients who are uninsured or housing insecure to is a huge benefit. Our data from our program has shown that if you see a physical therapist for any reason, you're about 18% less likely to bounce back in a 9-day window. And that's a measure that many emergency departments look at, is bounce back. And if you see a physical therapist, you are 50% less likely to bounce back for that same reason. And I think the thing that I see the difference is are the time we spend with patients, the patient education that we provide, our ability to empower patients with a plan to help themselves, and our ability to connect them to follow-up services are the main things that we provide. That trust and buy-in that you have when you take the time to evaluate a patient, other providers in the emergency department don't have that same luxury of time to spend with patients, but we do, at least in my emergency department, and I know that's not the same for everyone.
Yeah, I'll add to that. I think the benefit that I see specifically with musculoskeletal complaints is kind of that pain science education portion of it. My ability to sit there and kind of explain what I think is going on. If you think about, the patients are coming in the emergency department with a low back pain or pretty significant, what they think is a significant musculoskeletal injury. And for me to kind of say, like, it's okay that it's painful when you move, because if it isn't painful all the time or something like that, it's probably something a lot more serious. Well, it's a good thing, that you get more pain when you move, because that means it's probably a musculoskeletal thing. And this is how it's going to get better and things like that. And those are things, our physicians who are great don't really have a lot of training on. And for me, especially that time I spent an outpatient, to be able to sit and talk with them and kind of explain everything, I think that's super beneficial for the patients, and also for the providers too. And that now the patients are kind of calmed down. It's not the end of the world. They need back surgery or anything like that. It's just a little sprain or something, and then everybody's happy and they kind of move on.
I think that's so true, just helping decrease the fear, because people don't come to the emergency department because they're bored. They usually come because they're really scared and they're in crisis. So I often say, hey, if you're seeing the physical therapist, that's a really good sign. That means that there's nothing critical happening. It means you're not in any life-threatening danger. It's okay to move. So many people need to hear that. They'll say, oh gosh, I just didn't move because I was afraid I was damaging myself, or I was going to make it worse. Well, the good news is it's okay to move. It's safe to move. And I think of the people that we see immediately after injury, the workers' comp patients who come into the emergency department after a lifting injury, or even I've had patients come in after an electrocution injury. So many things where you can just empower them immediately. Right after motor vehicle collisions, you will have pain. You may have pain, but if you keep moving and you follow these different strategies, this is what you should expect. And patients really respond to that. I think too, the number one complaint I hear from just friends and family is, I went to the emergency department and they didn't do anything for me. And that's not the case, right? Like really, they made sure you weren't having a life-threatening emergency. And if there was something they were able to do for you at the time, they were able to do that. And they may have connected you to a specialist or some follow-up resources. But when we see a patient, they feel like someone did something for them.
We're also in Madison a non-opioid, I don't even know the correct term, but all of our emergency departments of the 3 hospitals in town have agreed not to prescribe opiates out of the emergency department. So basically the patients can't shop if they're looking for pain medications. But that's another role where we fill, where the physicians can say like, you know, I'm sorry, I can't give you prescribe anything more than ibuprofen, but I'm going to have physical therapy come in and work with you. And that's another provider satisfaction, is that they have something else to give to the patients besides like, yeah, there's nothing wrong. Well, there's nothing serious wrong with you. Here's some ibuprofen. They can actually give physical therapy treatment to them. And I think that's a big satisfier for the providers.
I'm trying to back up with some of these questions in here.
Yeah, we're gonna hunt them down for you, Rebekah. We're gonna rapid fire them to you guys and just let you guys take them, because I think there's a lot of great questions coming in. Some
yes, for sure.
Very practical and very specific care pathway questions. So Devon, what stood out to you as you were going through those?
Yeah, so kind of combining a few. What are some of the like consults that a PT in the emergency department would see? And as far as like treatments, you went over the pain science. What's like a typical plan of care? And how do you interact with other hospital staff, like nurses?
Kyle, do you want to go first or you want me to go first?
I'll start. So we have 4 main things that we generally see. The 2 main ones are fall risk assessments, and then back or neck pain. And then a little bit less than that is probably some extremity pains. So like foot, ankle, shoulders, knees. And then the 4th would be a dizziness, vertigo, concussion kind of thing. But the top 2 obviously are fall risk assessments, and then low back and neck pain. And this is a little bit off topic, but I think this comes up a lot, is a lot of times I hear of like outpatient providers or PTs thinking that they're just going to drop an outpatient PT in the emergency department and work there. And I don't push against that, but my main concern always with that is that you have to know how really good fall risk assessment and evaluate a patient and determine if they're safe to go home. I think that's the most valuable thing we do in the emergency department. If you want to get down to the nitty gritty, cost wise, if you save a patient from going into the hospitalization status, you deem that they're safe to go home instead of being admitted, that saves the hospital a lot of money. At my hospital, it's $11,000. So anytime we can save a patient from being admitted to the hospital under observation status, it's a big win for us. But just in general, like doing a fall risk assessment, the nurses don't have a lot of training on what to look for, or what they need to know in order for this patient to safely go home. And our ability to look at a patient and kind of determine whether they're safe or not, with all the other factors going around it. You could see a patient that gets up and moves around just fine, but they're the primary caregiver for their significant other who's 90 years old. Is that patient safe to go home? You know, all those things kind of go into it. So you have to be really, 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 really skilled doing a good fall risk assessment. I think that's the most important thing to work in the emergency PT.
I'm going to follow up your comment about dropping an outpatient therapist in the emergency department too, because I have seen more patients with critical issues and problems that are still emerging in the emergency department than I ever have in the intensive care unit. So you have got to be able to monitor vital signs. You've got to be able to interpret what patients are going to need. You need to be able to titrate oxygen demands. You need to be able to understand a lot of metabolic issues. You need to be able to understand cardiovascular pulmonary issues. So many of these patients have major chronic issues. So I've had more like obviously emergencies in the emergency department than anywhere else. Just because we're seeing the patient doesn't mean the emergency has passed or that the diagnosis is complete. So I always tell students, like, don't feel comfortable that the emergency is over just because we're seeing the patient. It may just be still emerging. So I think that's a skill too, like making sure you're comfortable with all of those things, as well as durable medical equipment for sure. So I like to think of the emergency department as a top of scope area of practice and an all patient therapist versus an inpatient or outpatient therapist or a home therapist. I think we need to get away from classifying ourselves by setting and really like specializing in overall like solid patient care. I'm a neurospecialist. Kyle's an orthopedic specialist. We all have things to add here. So also typical diagnoses that we see, anything musculoskeletal, knee, hip, back, shoulder, SI, ankle, foot, neck pain, back pain, vertigo. We see a lot of patients for falls, trauma after motor vehicle accidents, assault, home safety evaluations, workers' comp injuries. Sometimes we'll see a patient and the physicians will be like, there's nothing wrong with them, but they can't walk. But then we get the patient up to mobilize and their blood pressure drops 35 points and their heart rate skyrockets and they desat. And it turns out they have like a really abnormal hemodynamic response to activity, but we're the people that really suss that out. So we work really closely in our department with the team. And my favorite part is being part of the team. In other areas of the hospital, you know, you talk just to the nurse. You don't really have any face-to-face time with the physicians or maybe the residents, but in the emergency department, you're a consultant. You're not like a technician filling an order, you're a consultant. I'm calling Dr. Griffith because I would like you to consult on this patient, just like they would consult the neurologist, the orthopedist, the trauma surgeon. So when I am in the emergency department, I feel right here with my attending providers. There's none of this. And that's one of my favorite parts, is we are truly treated as a consultant and equal member of the team. Because our emergency department providers are so adept at finding the people that patients need. They know when to call the cardiologist. They know when to call the hospitalist. They know when to call the physical therapist to get the patient in front of them what they need. So I find our providers to be excellent gatekeepers of what patients need. I would say the nursing staff in particular, we have a really good relationship with because they want to know how to keep these patients safe. They want to know what our thoughts are, and they want to actually turn over beds too, so that they can keep the throughput in the emergency department going. So I think the other smart thing too in working in the emergency department is lend a hand. Like when you're in there with a patient, if they're soiled, like help the nurse take care of that. There are not a lot of hands in the emergency department and it's all hands on deck. So I think that helps our rapport with different providers. Our emergency department actually has a number of different teammates. We have behavioral health folks, so they do the same thing we do. They make sure patients are safe to go home, but from a mental and behavioral health perspective instead of a physical health perspective. We have our case management staff who help us with placement and discharge needs. We have our social workers. We have physicians, residents, nurse practitioners, physician assistants, respiratory therapists, pharmacists. I've learned so much from the pharmacists in the emergency department. Even our security team is so vital. And I think the unsung heroes of the emergency department are the custodial staff and the environmental service folks, because they have to really deep clean each of those rooms very quickly. And in a pandemic, that's been so crucial, trying to make sure that we're not spreading disease from room to room. And those folks do a really good job. So I would say we're all just a huge part of the team. And I haven't really had any negative interactions in this area.
Yeah, I would agree. I haven't had very many negative interactions either. Just think about a patient I saw yesterday, which is kind of a complicated vestibular one. And like you were talking about, everybody was on the same level. I went up to the doctor and the PA, and we all kind of talked about what we had each seen and whether we should go through with a CT scan or not, and kind of all decided at the same what we want to do with the next step. And that's a pretty typical interaction, I would say. Yeah, and I agree with the nurses. Nurses love us. Every time I'm down there, I hear from somebody else like, oh, it's so great you guys are down here. Definitely increase our throughput time so they're happy with us, and they're happy that patients have another service. I'm curious, Rebekah, I don't want to put you on the spot, but how you feel about new grads in the emergency department. I know I have my thoughts on it, but just want to hear what your thoughts are, since we do have a lot of students here.
Sure. I just want to add
maybe I'll just quickly interject. There's a question very related to this that you can address along the way. That was about what would students need to be successful in a clinical rotation in the ED as part of their preparation as a new graduate. So maybe you can address both of those along the way.
I just wanted to add real quick, plan of care, somebody asked about plan of care. My plan of care is to get the patient out of the emergency department. So, I mean, that's the bottom line. Can they go home? No. Can they go to subacute rehab, acute rehab, home care? Do they need to be admitted to the hospital? Do they need outpatient PT? Do they need a referral to another provider? Do they need a walker? Do they need crutches? Do they need family training? Do they, whatever it is that will get them out of the building? Am I the person that's getting them back to playing soccer? Nope. Am I the person who's getting them out the door? Yep. So that's my goal. How can I meet the patient's goals with our shared goal of getting the patient out of the emergency department? So it's definitely a different plan of care for every patient. I would say it really just, I know this is every student's favorite phrase. It depends what the plan of care is, but is it pain relief? Is it durable medical equipment? Is it family training? Is it placement? Whatever it might be. And then we move from there. But the goal that you focus on and start with is out of the emergency department and to the next step. So as far as preparing students to be in the emergency department, I have a student with me right now, and I just had a student with me, in the spring, and that was her final clinical rotation. And to Kyle's question, I would say overall, having a new grad in the emergency department is really difficult. Some of it is time management. Some of it is stress management. The emergency department can be stressful. It can be traumatic. One thing that I've learned is you never ask anybody who works in an emergency setting what the worst thing they've seen is. Because even as a physical therapist, I have things that I'm not going to talk about because it's traumatic. So you have to be the kind of person that can hold that. You also have to be able to communicate really well and confidently. And when I see in new grads and students, sometimes is that you're just not quite ready to confidently trust your judgment. That being said, there are exceptions. So the student that was with me last, we hired her because she did a phenomenal job and worked in the emergency department with me for, I think, 3 or 4 months. And so she's now rotating in on our team and is doing really well. There are times where she needs to reach out for more training or mentorship, but it is possible. So there are definitely PTs who have done it. But I think that in order to function top of scope, really working on understanding all of your different systems and being comfortable with all of those things, in addition to insurance rules, hospital policies, facility barriers, discharge barriers, social determinants of health, all of those things, and then doing it really quickly and confidently in a multidisciplinary, fast-paced setting can be challenging for some new grads. So I wouldn't say no. I would just say definitely you would need to have probably a clinical in it and really feel comfortable with all of those things. For some people, those are negatives. For other people, they thrive on those things. So I think it just depends on the person.
Yeah, I would agree. The one good thing about new grads, and I'm sure you probably feel the same way, Rebekah, about it, but some of your colleagues, if you sent them down to the emergency department as an acute care therapist for 15 to 20 years to see like a low back pain would not be good. And I think new grads just coming out of school have some more experience in those things, are fresher in those topics. So compared to some other PTs, I think they would be good in that setting. But obviously there needs to be some type of mentorship role and somebody to reach out to when they do have questions or problems and things.
Yeah.
I think that that's absolutely true. Some of my colleagues just will not come down to the emergency department because they don't feel like they could provide the level of care that our patients need because they're specialists in other areas. It doesn't mean that they're not good PTs. It just means that's not their jam. Like they can't pull out a low back pain eval from their brain today. They work on the neuro unit and they're exactly who I'd want to see my family member if they had a traumatic brain injury, spinal cord injury, or whatever the case may be. But it's just not for them.
So do y'all think that this could be like a really big section for PT moving forward, like where physical therapists are hired, specifically for emergency departments to work full time and exclusively handle like that type of patient load, that caseload?
So I think there's a few things there. First, emergency physical therapist practice does not be limited to the emergency department. That is one place where physical therapists can practice emergency physical therapist care. So I'm hoping that you guys have a couple more sessions. There are PTs who do emergency physical therapist practice in the wilderness. There are PTs who do that in combat. There are PTs that staff sidelines. There are PTs who do disaster relief. So if from nothing else, I want you to take home with you that emergency physical therapist practice is not a location. It's a treatment strategy. It's a mindset. And all of those things fall under that umbrella. And I think too, as physical therapists, and particularly as students, when you look towards the job horizon, I challenge you to think with some innovation. Where are physical therapists needed and where are they not right now? Because I think it's 7 to 10% utilization of physical therapist services in this country. And that's just in our regular spaces. So if we can expand to those spaces where we're needed, but we're not currently filling the demand, the potential for physical therapists and the future of physical therapy is amazing. So I want you to just think about that. I think every hospital should have a physical therapist they can at least consult with in the emergency department. It may be that they only have 7 beds. Do they need a physical therapist sitting there the whole time? Probably not, but should they be able to reach one? I think so. We're going to be giving a presentation at CSM about digital triage and how to keep your patients maybe out of the emergency department. And can you set up a digital triage to really look at patients and say, hey, yeah, I think you should go to the emergency department, or no, let's get you scheduled with a physical therapist right away so that we can fill some of those gaps. But right now, it's definitely still a practice area that has lots of space to expand. And I think if we don't continue talking to students about it, it won't.
Yeah. All right.
I'll add to that. One of my soapboxes recently, I saw this article, I think this summer, where they compared when an urgent care opened up in an area with a major hospital, what happened to the visits in the emergency room versus the urgent cares. And for every ED visit that got reduced because this urgent care was open, there were 37 urgent care visits. So their cost savings was really nothing from opening up this urgent care. And I actually think that urgent care is probably where we're missing a lot of these patients that we could be seeing for physical therapy. Now, a lot of towns, there might just be an emergency department, so there's no option for urgent care. But I always think of those little musculoskeletal injuries, you know, your neighbor might think like, man, this is really, really weird. It doesn't feel right. Maybe I should just go get it checked out. That could be an awesome opportunity for physical therapists. So those of you who are working in big hospital systems or possibly down the road looking for jobs, big hospital systems, I actually think that would be a place that I would look for specifically if you want to get involved in this area for physical therapy, because I think there's a lot of need and a lot of patients that we could potentially reach in those areas.
Yeah. I think it's just an amazing untapped area. And there's so many questions that people have about this in the chat. So I think maybe for our last 15 minutes, we can do some rapid fire question and answers, because there's some like specific practice and clinical pathway questions that I think are really interesting, kind of in the weeds, but I think are important. And then there's some very specific questions about navigating some of the challenges within the ED around different state laws and the patchwork of rules and regulations that might affect PT practice that you guys might be able to address. So if you guys don't mind, we can do some rapid fire question and answers, because this is the most questions we've ever had in this forum. So I want to try to get to as many of them as we can. So Devon, I know you've been compiling a list for us and I've been tweeting them out, so go for it.
So one of the earlier questions from Susan, so her hospital is trying to implement a system if they can get patients straight to subacute rehab, if they're appropriate, from the emergency department, since they have a facility down the block from the hospital. What are some pros and cons to this?
So we have always done that with patients who have insurance that allows for that. However, during the pandemic, Medicare has waived the 3 midnight rule, where patients had to be in the hospital for 3 midnights in order to go to a subacute rehab facility. Best thing they've ever done. Like, why do we want to put patients in a hospital bed for 3 days, just deconditioning for longer, just to go to subacute rehab when they don't need to be in the hospital? And like Kyle said, if you think $11,000 is saved by not sending that patient to the hospital, those are some pros there. I think also when patients don't really have medical needs, they have rehab needs, the right answer is to get them to rehab as quickly as possible. So I think I'm very hopeful that this is permanent, because when you think about the hospital overcrowding that's been occurring because of COVID, I saw somebody put in the chat that they've been boarding a lot of patients in the emergency department. Us too. Like, we have a whole patient PT that comes down just to see the inpatients that are boarding in the emergency department. So if we can get patients to acute rehab or subacute rehab without these prolonged authorization stays, I think it's a win for everyone. I think it reduces costs across the board and helps the patient get the appropriate care quicker.
I agree with all that. The problem that we've had is just a lot of red tape and getting specifically the skilled nursing facilities approving from the ED quickly. And sometimes they'll need an occupational therapy evaluation for them to be discharged directly there and things like that. So there's a lot of red tape that you have to go through. But if you get the system set up and it works, I mean, I think it's a perfect situation.
All right. So question from Adrian. You mentioned having a physical therapist see a patient instead of a PA or a nurse practitioner. Does an MD still oversee the emergency department visit, or do the PTs triage and refer to the MD if non-PT issues arise? And I think they're assuming that you need direct access for that.
So this is going to be a pilot program that we're starting in January. So I'm not entirely sure how all the kinks are going to work out, but because of EMTALA, which is the law that states that if you come to the emergency department, you have to be screened or triaged by a qualified professional. Right now, physical therapists do not fall under EMTALA. There are people that are working towards that, because if you have direct access in your state, and you should be able to tell if somebody needs emergency care or not. But so the way that this will work in our hospital is these patients will come in and be triaged by a physician to the PT or to the nurse practitioner. So they will still have contact with the physician, and then we'll manage their care from there, including ordering imaging or referring to the NP or the APP if there are medication issues or any medical red flags that we uncover. So it'll still be a team-based sport, but instead of us consulting the PA or the NP, or consulting for the PA or the NP, we will consult them for our patient management. So if the patient needs to see an orthopedist, we'll call the orthopedist, so it'll be more us holding the bag for those patients. So direct access isn't necessarily needed because it's in a hospital system and they're still seeing a physician, although Colorado does have direct access. But this is because of the facility, it's a little bit different than that. I hope that answers that. But I'm really looking forward to how this turns out, and I hope we can do a presentation about that and just our findings on how this goes.
I have nothing to add.
Okay. So y'all talked about how seeing a PT helped your hospital save money because they didn't have to be admitted to the hospital. So in terms of imaging rates, does seeing a PT decrease those rates as well? Like, what other areas is seeing a PT saving people money?
It depends. I feel like sometimes we decrease imaging, sometimes we increase imaging because we have other findings. For example, I had a patient who came in with vertigo, but when he described his symptoms, it was like, I just kept asking questions. I said, have you had any neck pain lately? Have you had any head injuries? Well, yeah, my neck has been hurting a lot, but it feels better now. I said, okay, well, what did you do for your neck? He said, well, I saw the chiropractor. I said, well, when did this vertigo start and this blurry vision and this double vision that you have? Like, when did that begin? Well, it started after I saw the chiropractor. So I'm not going much further there without just making sure he doesn't have a vertebral artery dissection, because the man's losing vision and he's ataxic, all kinds of red flags there. So that patient was passed to me with no imaging, but then I referred that patient back for imaging to make sure that they were safe. So it just depends. Sometimes we increase, sometimes we decrease. At least in my perspective. Kyle, I'll do what you think.
I would agree. I think there's a lot of musculoskeletal things that get sent to us, and we're like, yeah, I think it's definitely this, no imaging needed. I think a lot of times I end up causing CTs of hips or pelvis. Rebekah, you feel the same way, but x-ray's negative, they've had a fall, then we get up and stand and they can't bear weight on one side to walk. So I'll go back to the doctor and say, they can't weight shift at all to walk. I don't know what's going on. It's all right, we'll probably have to CT then. And sure enough, they CT and there's a hip fracture, pelvis fracture. So yeah, it goes both ways.
But we almost never ask for an MRI. So if we ask for an MRI, they know we're serious.
Yeah, it sounds like most of the imaging increases are probably appropriate increases, like things that could potentially lead to more problems if you're not identifying them. Okay, there's a good follow-up from Anna there, yeah.
Yeah, just saw it, Anna. So are PTs able to order imaging in the emergency department, or does the MD have to order it?
Presently, our MDs just do order it because they're the ones that will manage the follow-up, and we're seeing multiple patients. So I just say, hey, I think this patient needs X, Y, and Z, and then they do that. It's just like in our hospital, if the orthopedist sees a patient, they will tell the emergency provider that the patient needs a CT or these views or whatever. So that's just how it's worked. However, when we start managing these patients in our pilot program, we'll enter the imaging orders directly ourselves. However, Colorado is a state where PTs can order imaging.
Yeah, I can order imaging as well. I'd say the same thing. I think for the physicians, it's literally like 2 clicks to order something, where me, it would be like a 5-minute process to put the order in. So if I just tell the provider, I'm like, hey, I think they need this, they'll just do it in 2 clicks and it's done. Saves everybody time.
Yeah, those are, I think, some really compelling financial value reasons to be thinking about, PT in the ED, for ordering imaging that is appropriate and saving downstream complications, a fall or, some sort of nursing home admission. I think that is a really valuable use of our service. So I want to open the floor to others that maybe haven't had a chance to ask questions yet. And Devon and I have been monitoring the chat pretty intensely. So if we missed your question and it's burning in your mind, let us know. So we'll keep the floor.
Can I also just plug a couple things, Jason?
What's that?
Can I plug a couple things real quick?
You have the floor, Dr. Griffith, so you can plug it.
So, I love that. So if you're interested, there is a Facebook group called Emergency PT on Facebook, and that is a place to connect with a lot of other people who are interested in this. There's also one specifically for students. So it's EPT and EPT student. And then this weekend, there will actually be an emergency physical therapist continuing education conference, along with a business meeting on Saturday. And I don't have that information to link here in the chat, but you can find it on that EPT Facebook group. It's a pinned post there. For students, the price is $25. So I think that's a really good deal if you're interested. If you don't want to come for the content, you can certainly come for the business meeting. Kyle and I are both part of an EPT steering committee trying to do what we can to advance this area of practice. My role is the outreach person. So that is, I'm trying to reach all of you today. So if you have people who want to hear more about this, or you want to expand this in your state, or you have questions, please feel free to contact me. I think the best way is probably through Twitter. And there's something else, Kyle, that I'm supposed to promote. Facebook groups and the conference, maybe that's it. Oh, there are multiple presentations at CSM that will be about emergency physical therapist practice. There's the one on digital triage that I talked to you about before. And then the HPA, the Catalyst section, is going to be having kind of a TED Talk almost with several different providers. I'll be speaking about emergency PT practice. There will be a PT speaking about wilderness PT, one about disaster PT, and one about combat PT. And it'll be like 15-minute short little presentations that I think will be really interesting. We also usually have a meeting and social event for people who are interested. Students are more than welcome. So we would love to have you involved in any of those ways.
Awesome.
I linked the conference this weekend on the chat, so definitely check that out. These are like top people in the world that speak at these. So these are the top people, like way higher than me, speaking at these events. So
yes, not me, it's not Kyle. It's people who are really experts in this area.
Oh, well, you both really have taught us. Well, you both have taught us a lot tonight. You gotta give yourself some credit, okay? We do have a question from Lexi. It's a really good one. With both of you having specialties, Do you ever continue working with the patients once they move to subacute PT, or do you just refer them out to another neuro or ortho PT?
I'm kind of a weird bird in that I only work part-time as part of my life work balance commitment. So I almost never see patients again. I also don't have any outpatient capabilities, so I usually refer them to people in the community that can see them. And if they go to the floor, they see whoever they might see in that area. So I don't ever continue working with patients, although I will tell you, I do have some frequent flyers who come back every once in a while that I get to see and get to know a few special folks. But no, unfortunately not. But honestly, that's one of the things that I love about my job is that I don't get overly invested in my patients. When I was starting out as a PT, I felt that my empathy drive was a little too high, and I spent all my time when I wasn't at work thinking about my patients. And one day I felt like totally paralyzed by carrying the grief that some of my patients were carrying. So for me, acute care and emergency care, I look at it like I'm a guest star in that person's life. I'm on this episode of their life, a Rebekah Griffith guest star, you know, and I give them everything I can in that moment. And then I seal that practice with that patient and I move on to the next one. And that allows me to give each patient my very best without having to take pieces of myself out because I was holding too much. And not everybody is that way. But if you find yourself feeling that way, there are ways to cope with that.
Yeah, I'll add, I think the biggest question I get, and not necessarily with emergency PT, was what's the difference between working in inpatient versus outpatient? And I know there are a lot of students on here. And I love working outpatient. I still do a little bit on the side. Love forming relationships with patients, getting people back to whatever they were doing. But I always tell people that like, it's definitely more stressful working specifically with patients in the emergency department or maybe on acute care. But like the other 99% of the job is just way less stress in terms of documentation, time management, things like that. I felt like outpatient was a lot more stressful in those areas.
Flexibility.
So, yeah. So in that area, like my life is a lot less stressful because I'm not stressing when I'm home about the 20 patients I have to see tomorrow on outpatient.
Mm-hmm.
I'm going to go work in the emergency department. I have no idea what I'm going to see. It's going to be a good day no matter what happens.
It's like a choose your own adventure book.
Yeah. Outpatient, one thing goes wrong in the morning, man, the rest of the day you're kind of playing catch up. So just something to think about. Not going to steer anybody in one direction versus the other, but it's definitely a benefit I feel like from working in the emergency department and acute care is that less stressful environment, I guess. Although I got to get to work on Christmas this year, so.
I worked on Thanksgiving.
Yep, see, there you go.
One of my children said to me, you need to stop working on holidays and weekends because those are the times that I'm available to spend with you. I was like, bro, I've been doing this for your whole life. Like, you need to get over that.
Yep.
My first emergency department experience as a PT was a gunshot wound in Wyoming for somebody hunting and accidentally shot themselves through their calf wound. And I had to come over from Cheyenne to Laramie, Wyoming on Thanksgiving and teach somebody how to use crutches and, you know, help deal with a couple of orthopedic things and send somebody home. But that was my first foray into the emergency department. It was a lot of fun, despite a somewhat sad circumstance of somebody discharging a firearm into themselves accidentally on a holiday.
Halloween was very well for us this year with gunshot wounds. I don't know what it was, but Halloween was not good.
Yeah.
One of my favorite ED PT stories was Christmas Eve 2 years ago. I had a patient that was, again, like 5:15 at night with hip pain. And she told me, she's like, I want to make sure this isn't fractured and I'm going home because I have 25 people coming over. I'm like, great. No fracture. Got her a walker. She got out of there. She was happy. The provider was happy. Nursing was happy. I guess I was happy staying late on Christmas Eve. But I think, like Rebekah was talking about earlier, like, being on that same level with everybody, the nurses and doctors were going to be there all night. I just had to see this one patient a little bit late, and everybody worked out well together, and it was a positive experience for everybody. So
we are the only discipline that doesn't get relieved with another shift. So sometimes I think the other providers don't understand that, like, when they leave, someone else comes in and picks up the ball and carries it. When we leave, nobody comes for 12 hours. So that I think can be frustrating. And they've asked us, can you provide physical therapy 24 hours a day? My response is usually nobody wants to do physical therapy in the middle of the night, especially the physical therapist.
All right. Well, this was a wonderful conversation. So I'm going to just formally close the official session, though. I will leave the room open after I stop the recording. But I wanted to formally thank you both, Rebekah and Kyle, for joining us on a late night for us here on the East Coast, a little earlier for you guys, but still taking an hour or two out of your day to plan and come and share this experience, which is so unique and just such an interesting area, and one that I think is very, very underutilized across the country. So I think there's a lot of models and practice patterns that you shared that might help people start their own EDs in other settings, community hospitals, maybe rural hospitals, where I think PTs certainly can provide a lot to those patients and into the broader communities. So on behalf of us here at PTJ, we're really thankful that you could join us. I'm going to go ahead and stop the formal recording. We're going to post this up on our YouTube page, and we'll send out the links for you guys to be able to access later on once we get it all cleaned up. So I will stop.